3.
Hello again, Dr. Anthony Gonzalez here. Welcome you to Miami Community Health, another episode of another health topic to inform you on what's new in our world of health. Once again, I have an important topic to discuss with you today. As you may or may not know, it's National Stroke Awareness Month. And so, of course, strokes are very important. People hear about heart attacks. And of course, strokes are as important as heart attacks. And what better to talk about a stroke than a neurologist? So I brought a friend and a colleague, Dr. Paul Damski, with us today to talk about strokes. Welcome, Paul.
Hi, Tony. Thank you very much for having me. And just for your listeners, you really should understand Tony's really been an asset to the community and does this show. He does volunteering in Haiti and a whole bunch of things, and really we should be very happy with him. I'm a neurologist. I'm an adult neurologist. I do a lot of stroke care. I used to be the stroke director at Baptist Hospital. Now I do just sort of general neurology. I've been practicing for about 20 years or so. And I'm mostly at South Miami down the street. Also spend a fair amount of time at Baptist and West Kendall.
So we're going to be talking about strokes today. And so the first question I have is, what is a stroke?
Yeah. Well, stroke generally is a problem with the blood vessels and circulation to the brain. So either there's too little blood most of the time, or sometimes there's too much blood. An area of the brain doesn't get enough blood typically. The brain needs a whole lot of blood because it's got a lot of metabolism that it takes care of. If it's not getting the oxygen, if it's not getting the sugar that it needs, it just doesn't function very well. And if it goes long enough, which is really not very long, it's just a few minutes, that part of the brain can actually die off.
So it's like people compare it to a brain attack, like a heart attack. It is a brain attack, right? It's like lack of blood flow to your brain.
I tend to prefer the old English terms of stroke and things of that nature. But yes, brain attack was actually taken up by people, but it's basically the same type of thing. With the heart, you're not getting blood to a certain part of the heart. Here, you're not getting blood typically, or there's just way too much blood. A blood vessel opens up and you get bleeding in there.
So there are different types of strokes, right? I mean, you can have, I've heard mini strokes and massive strokes. You know, educate us on what the types of strokes that exist.
Sure. The mini stroke versus stroke title is something that's really based on time. We don't use mini stroke so much, although everybody comes into my office saying, I had a mini stroke. That's typically something that lasts only about an hour. It can go up to 24 hours, and it's always reversible. So somebody has a blood vessel, it's not getting blood, they can't, let's say, move an arm, they can't talk, but it gets better. So you don't actually have too many dead brain cells, or you've got some dead brain cells, but not too much. With a regular stroke, it's actually gone beyond the point where you then have dead brain cells. So either it's just a timing issue. Somebody comes in, they can't move their arm for a while, and it really lasts more than 24 hours. It goes on for several days. Or they have a short episode, a transient episode, one that seems to reverse itself. But when we do pictures of the brain on MRI in particular, we see that there are actually areas of really dead brain. So that's the difference there.
So even if it only lasted a few minutes and there are changes on your MRI, then it's no longer a mini stroke, it's a real stroke.
That's correct. We would consider that an actual stroke. It usually takes up to about 12 hours before you start seeing the dead brain. But sometimes even within the first hour, you will see that. And probably if you're looking under a microscope in somebody's brain, which we don't do normally unless it's too late, you're going to actually see some dead brain cells.
Yeah, for our viewers, don't let anybody biopsy your brain. Like that's not a good idea, right?
I would certainly suggest against autopsy until the right time, basically.
All right. So who's getting a stroke? I mean, let's talk about, gender, age. Are there medical problems, people with cholesterol, smokers? Who's getting a stroke?
Well, the usual thought is just some old person gets a stroke, but in fact, everybody can get a stroke. As one gets older, one has more time to suffer from the consequences of a lot of different types of risk factors. So for instance, high blood pressure or hypertension is probably the main source of stroke. With that in particular, you're getting blood vessels which have been fighting with this blood pressure. They tend to get harder. They've got some inflammatory cells that are there to just really, normally were there to fight infection and such, but they see damage. They're trying to correct that, and they get tighter and tighter and tighter. And sometimes they lead to a blood vessel that is very tight or closed off completely, and then a surgeon might go in, for instance, and try to open that up. But over time, you'll find those types of changes. Additionally, you'll get problems with the heart. So people who have had some heart disease, especially something called atrial fibrillation, that's a problem where you've got 4 chambers in the heart. So they're little rooms, essentially. You've got the right side, which sends stuff to the lungs, and then blood comes back from the lungs, goes into the left side, goes into the atrium, which is the top part. Then it goes down into the ventricle, and then it goes up into the brain and all over the place. So sometimes when that atrium, the top part, is not pumping out blood properly, where the blood comes in, the blood goes out, and it just kind of wiggles around. When blood doesn't move, it tends to clot off. So you'll get these clots in the heart, and that will go up to the brain. So that would be another risk factor, for instance, somebody who might get this. With the high blood pressure, in addition to those tight blood vessels, you also pop open blood vessels sometimes. And you'll see, especially with younger people, they might be using cocaine, for instance, where suddenly there's just a major surge of blood pressure, and all of a sudden, boom, out pops the blood, and you've got a big area of, the skull is a locked box. There's no room for expansion except when you're a little baby. So when you pop open the blood vessel and all of a sudden you've got all of this pressure, it pushes against other brain structures also, and that doesn't work. There are a lot of other kinds of risk factors, but anybody can get it, but there are some things which tend to predispose you to getting it.
Right. So what I'm listening is obviously advanced age, high blood pressure, of course, a drug use, and then cardiac conditions as well that can cause that. Now, can you prevent a stroke? Obviously we're talking about stroke and stroke awareness, but I think the best way to deal with a stroke is to never have a stroke. How can we prevent a stroke?
Yeah, when we talk as doctors about prevention, we talk about different levels of prevention, essentially. So there's primary prevention, which is what you're really discussing here, and there's a secondary prevention. Usually as a neurologist, I'm seeing secondary prevention. Someone has already come in to the emergency room, they've had a stroke, I help them get through that, and then we try to figure out what was the reason for that stroke. So in some cases, for instance, there's a blood vessel that was tight, we deal with that, we try to prevent the next stroke from happening because we know there's a high risk of another episode. So for instance, someone who comes in with a small stroke or one of these transient ischemic attack or that mini stroke, TIA, we'll then look really closely what caused that, because they have a pretty high risk, especially over the next 2 to 3 months of developing another stroke. Now, what you're asking more generally is somebody who's never had a stroke. They're 30 years old. They're wondering, how do I avoid this? My mom got a stroke. I don't want to have the same thing happen to me. As with really all of these heart and blood vessel diseases, you got to watch your blood pressure. You should be doing exercise, a moderate amount of exercise, probably 3 to 5 times per week. Try to minimize some of your salt, especially if you have some high blood pressure. There's some question about will taking aspirin help, things like that. We don't have a whole lot of proof that if somebody hasn't had a stroke, they will prevent a stroke by taking it. So I would really stick with the basics, get your exercise, eat well, watch the blood pressure, check in with the doctor every now and then.
So basic health, like we've talked a lot of times on this show, basic, just general health precautions, everything from eating healthy, doing exercise, being ideal body weight, and controlling your medical conditions or avoiding medical conditions is going to prevent you to have a stroke. Now, how do we know somebody's having a stroke? Whether it be a loved one, you're with mom or grandma, or you're at a restaurant and someone next to you. Now Miami's back open with the COVID. How do you know if somebody's having a stroke? What are you going to see? What is the layperson going to notice?
Well, it's always a question of real estate with a stroke. It's what part of the brain is affected. But the typical things that you're going to notice will be somebody can't talk very well. Their face starts to droop. You have an arm which all of a sudden stops working. You can't lift it up. There are a whole variety of things. Everything that you think and do resides in your brain. So really any kind of symptom that you can have from the brain can be affected if it's not getting enough blood. So you will sometimes see things like just severe dizziness. A lot of the times that's not a stroke, but unless you really know what you're talking about, you should go get that checked out. So basically any kind of sudden change in ability to do any of this stuff, see, vision, etc. We use a FAST score when we're doing some outside evaluations of stroke. So things like face, arm, speech, and then figure out the time. It's important if you do see somebody, let's say you're at a restaurant and you see somebody suddenly unable to talk, try to figure out what time it started, because when I treat somebody, I need to know exactly what time things started, because that changes the kind of medication or other treatments I can give them.
So really, besides calling 911 and noting the time, there's not much else you can do for that patient.
If you happen to know CPR, it's probably not a bad idea. Check the pulse, make sure they're breathing fine. The very basics of all these ABCs that we talk about, airway, breathing, and circulation. In general, there's not a whole lot to do, but 911 is an important factor because the earlier you get in, we call it time is brain. Part of the problem, you mentioned heart attack versus brain attack. And one of the real big issues we see as neurologists with a heart attack, you've got this pain or pressure, and there's something that's telling you, oi, something's bad here. With a stroke, sometimes you just feel numb, or you just have trouble getting a few words out, and it lasts for a few minutes. And it may not be so obvious that there's something bad, and you kind of blow it off and you say, I'll sleep it through, wait in the morning. When I was a resident, there was a guy who trained on stroke. He was a nurse. He taught at the simulation lab, and he ignored his dizziness until the next morning it was a problem. So that's even somebody who knows about it. So really, if you have those kinds of symptoms, you got to call 911.
All right. So you talked about the quickness, and explain to us how quickly should somebody get to the hospital, and why is the time important? How does that impact initial treatment?
Yeah. Quick is quick. Really, truly, every minute you're waiting, millions of brain cells are dying. So the earlier we can get treatment, and what we're trying to do in the case of this so-called ischemic stroke, where we don't have enough blood, is we're trying to bring the blood back up into the brain somehow. Typically what happens, we think in different circumstances, but there will be a clot, let's say, in one of the blood vessels, and the blood just can't get through that blood vessel and get out there. So we're trying to break up those blood clots. There are two main treatments that we'd use. One is an intravenous drug. It's called TPA. And to be able to give that, you need to be tipped best within the first 3 hours. So the very time that the symptoms start until the time that I get you with the drug in your vein, it's got to be up to 3 hours. We've expanded that to 4.5 hours for some people, although not for everybody. Beyond the TPA, there are also mechanical things we can do. So we have what we call neurointerventional radiologists. We've got a couple of Baptists. There are a few elsewhere in the city, not that many really around the world, frankly. They go in with a catheter. It's basically a big tube. They go up usually through the groin, wind it up into the blood vessels in the brain, take pictures of those blood vessels. And if they see a large blood vessel which is blocked off, they will go in there either with some of that medication that I would have given by the vein, or they'll actually put it a little bit into the artery. But mostly what they tend to do lately is try to break up the clot mechanically. So sometimes they'll put a stent, which is a little cylinder. They'll try to open that blood vessel and let the blood from below push it all the way through, and the clot will kind of break up into multiple pieces. Or they've got some older techniques where they go in with a corkscrew and try to yank it out. Or they go in, they just kind of muck around and try to break it up. But they do whatever they can based on the technology that they have at their hands and the patient in front of them, and they try to break it up. They have a longer window of treatment. The medicine that I give does have some risk. So about 3 out of 100 people who get that medication can die of the medicine. But the earlier you give it, the less chance there is typically. And 6 out of 100, so another 3 might have a massive bleed. So the earlier I give it to you, the less chance you have of getting that. But beyond the 4.5 hours, the risk of bleeding far outweighs the likely benefit. The folks who go in there with the catheters, they can go most typically out to 6 or sometimes 8 hours. And in really dire circumstances, let's say there's a blood vessel in the back of the brain called the basilar artery. That really keeps you alive, essentially. It keeps you up, awake, keeps you breathing. They will sometimes go up to 24 hours for that. So you don't want to wait it out. You really want to get in there as quickly as possible because we're limited in what we can do for you. And also just the more time you wait, the more dead brain you're going to have and less chance you're going to do well.
So what we've heard really is fast is important. Like you mentioned, the acronym FAST, get to the doctor fast, and then they act fast to try to deal with the problem and prevent any further damage. So the patient has gone to the hospital, they've had their intervention, whether you gave them the TPA or they got the angiogram and the intervention. What happens after that? Now they go to their room, and what is the recovery like, or what happens after that initial treatment?
Yeah, well, just to start, most people unfortunately don't get those treatments because they come in either too late, or like in the case of the medicine that I give, if they're on a blood thinner, for instance, there's too much risk to give it because they're going to bleed. So for anybody who comes in, whether they get that acute treatment or not, they will typically come in. We'll have to monitor them for a few days just to make sure they're not getting worse. In the case of one of these massive strokes that you referred to before, you may have a huge part of the brain affected. When brain is acutely injured, it will often swell. You'll get edema. So there's extra water production. The cells are dying. They don't know how to get the water in and out of the cells. So those cells just swell up. And I mentioned this closed box issue. So if you got a big stroke here, that can really get big enough to actually push the brain to the side and smush against other parts that keep you alive. So that actually can kill you. So in those big circumstances, people are usually there for 3 to 5 days just to watch the edema. Most of what we're doing the first few days is trying to figure out what really caused the stroke. Was it the heart problem? Was it a carotid artery, some other blood vessel in the brain, some other issue like that? And doing different kinds of tests. So the tests we'll do often will be an echocardiogram, which is an ultrasound of the heart. We're looking for clots there. We're trying to make sure the heart's pumping properly. We're looking at the heart rhythm, try to make sure you don't have that atrial fibrillation, which is just this irregularity that we see on the EKG. We'll do other kinds of ultrasounds typically, looking at the carotid arteries in the neck. We can see the arteries in the back called the vertebral arteries. And then we'll often do some kind of imaging. Pretty much everybody gets a CAT scan, a CT scan. That's basically radiation coming you from all angles. It's very quick. Every hospital has it in town, and we can just do it immediately. We see easily first, is there bleeding? Because bleeding shows up as this big white thing or not. And then often people will then go on to get an MRI, and the MRI is much more sensitive, meaning it's more likely to see a new stroke. And it also shows us other things. Were there evidence of old strokes elsewhere? Did they have bleeding from some other reason? Looking at the blood vessels, are there tight blood vessels in the brain that might have caused a stroke? Because if you've got something really tight up there, sometimes we'll have to think about doing that angiogram for that, or treating a bit more aggressively with some of the cholesterol medicines, the blood or the antiplatelet medicines like aspirin or things like clopidogrel. So we're really just trying to figure out what was the source of the stroke, how does it look, and is the patient doing okay? Is the patient getting better? A lot of what we then transition to is the rehab. So really within the first day, you're trying to see, can somebody swallow safely? You know, if you have something that's affecting your pharynx or your back of the throat and the muscles are not working really well, the voice may be affected, but they may also have trouble getting food into their pipe. So what happens if you're not swallowing properly, you eat something, it goes down to the wrong tube, it goes into your windpipe, and all of a sudden you have what we call an aspiration pneumonia. It's a pneumonia that goes basically from food that gets stuck in your lungs. So we want to avoid those types of things. We have a physical therapist work with you to work on the walking. We have occupational therapists to work on some of the arm movement. The speech therapist also helps with language and stuff. And then a lot of it is sort of social stuff. We have to educate the families. What just happened? You've never had an experience other than watching, Dr. Gonzalez's TV show here. What is a stroke? But all of a sudden it really hits home. Oh, wow, this is a big deal. What does this all mean to me? How do we deal with mom or dad or brother or sister, whatever the case might be? And then try to get them geared up. If someone's doing great, get them home. If they're not doing great, we have to talk about going to rehab possibly.
Wow. So there's a variety of interventions and of course outcomes. So it depends on how little or how large the stroke was. It depends on how they're going to do.
Sure.
Now, does the family have to be concerned? Is this a genetic issue as well? Should the kids and the brothers and sisters of that patient be checked for stroke?
Yeah, that's a tough question. There are clearly some genetic links. There are some rather rare genetic syndromes. So there are these what we call mitochondrial, which are the kind of the powerhouse energy parts of the cells. They will sometimes have mutations or changes in the genetics, and there are some families that have a very high risk of recurrent stroke. It's exceptionally rare, truthfully. Another thing that we'll see from a genetic standpoint, one type of stroke that I didn't mention would be what we call a hypercoagulable state.
Mm-hmm.
So the blood is normally supposed to clot. You get a cut and blood comes out, and if it doesn't stop, you're in trouble. So we've got systems in the body. We have platelets, which are these little sticky particles. They will start to stick initially, and then the liver puts out some chemicals called coagulation factors. And those will start once you have the stimulus that you've got open wound or something like that. A whole bunch of chemicals come together and they just basically cause a big clot. So some families have genetic disorders where they're more likely to clot. So they are hypercoagulable. So there are some circumstances, and this tends to be younger patients often. Sometimes we'll find women on birth control pills, for instance, and they were otherwise healthy, but they, because of the birth control pills, have a more likely chance of clotting, or somebody smokes, and tobacco use will increase the clotting problem as well. But then you may have that genetic factor mixed together with something else, which then makes someone clot. So in that particular case, a family member might at least try to figure out, have I had other things which look like there's a clotting disorder? Have I had miscarriages? That can sometimes be from that. Have I had clotting in the lungs, or deep vein thrombosis, or clots in the legs? So if you're getting a bunch of those types of problems, it probably makes sense to check in with a primary care doctor, and maybe even a hematologist, to take a look into it. There's probably some increased risk of stroke generally if your family member has had a stroke, just like for any other kind of cardiovascular risk factor.
Yeah.
So families that tend to get heart attacks, others in the family often do as well. But the fact is, we're all at some risk of getting it. So I think living the good life regardless is appropriate.
Okay. Well, definitely they're going to be concerned. So if the family member is checked out and they don't have any of those risk factors, any of those clotting factors, besides what we've already mentioned, we've talked about the healthy lifestyle and the eating correctly and the exercise and the blood pressure control. Is there anything else that they can do to prevent having a stroke, or can that even patient prevent from having another stroke?
Well, the patient who had the stroke, that's where we get into this secondary prevention. So we will, it really depends on the situation, and everybody is quite different. And frankly, I'll put 10 neurologists in a room and get 12 opinions. So typically what we're doing for the person who has already had the stroke, we will probably, if they have not had a bloody stroke, because if they've had a bloody stroke, we're watching blood pressure, making sure they were not using drugs, making sure there's no other clotting problem in the other direction where they're more likely to bleed out, and trying to just address those things. Get your blood pressure under control, especially. With the ischemic stroke, often people will be on one of these antiplatelet medicines, so aspirin or another medicine like aspirin. And lately we have been doing a dual treatment for a few weeks, because you have a pretty high risk of another stroke over the next few weeks, and that goes down. But the combination of those two medicines actually makes you bleed in your brain. So at the time where things start crossing, we say cut off, just stick with the aspirin typically. If somebody has one of these so-called hypercoagulable states, sometimes we'll have to wait a little while, because when you have an acute stroke, you've got some dead brain material. And when you have dead brain, the blood vessels die also, so those will bleed as well. So we wait a little while, and then we'll put them on a blood thinner. So that's something a bit stronger than the aspirin. One of the old medicines was Coumadin or warfarin. We've got a whole bunch of new agents that we use as well, but we'll often put them on that. If they've got the atrial fibrillation, we'll put them on a blood thinner as well. If they've got the carotid stenosis or tightening of that artery in the neck, then there are a variety of things we can do, and the timing sort of depends. But we'll open it up somehow, either with an angiogram type thing and put a stent there, or we'll do surgery to actually open it up and clean it out. Now, for the person who hasn't had a stroke, I'm not sure that there's much more than what we talked about. Is keeping a healthy life, which you should be doing anyway, just to enjoy things for a long time. Getting exercise, watching the blood pressure. If there's a certain circumstance with your family member, yes, you should probably check out if there's some genetic issues, but that's pretty uncommon, that portion.
Well, so we've learned a lot about stroke in the everyday life, and of course in the everyday patient. And of course, we had in the last year, we had this COVID pandemic. And how is COVID related to strokes? Is there, if you had COVID, does it impact you? And even more importantly now, because everybody's now in this vaccination world, is there any association with regard to the vaccine with strokes?
Yeah, well, this is my first day without a mask in public, so the world is changing right here. I feel a little naked here. I shaved today, thank you. COVID actually does seem to have some increased risk. Where it tends to probably happen, the clotting issues tend to be affected by COVID. And early on, especially before we started using some blood thinners, and I'm not talking about stroke particularly, but people would come in, they'd be really acutely ill, they'd get a horrible pneumonia, and the body, to fight the virus, would put out a whole bunch of chemicals, what we call cytokines and other kinds of chemicals. And it's really out there, it's just to kind of poison the virus and try to make sure the right cells are coming in to eat it up and stuff. When that happens, the blood tends to get thicker and tends to clot. So a lot of people were getting clots all over the place, and you can find it in the lungs and in the heart, and really every organ was getting it. Brain was no exception. Initially, we thought that it may even be as high as 5%, or 1 out of 20 people got a stroke. That probably is overblown. It may be that the number of people acutely ill in the critical care unit, the risk is somewhere hovering around the 5%. More recent studies have shown that about 1 out of 100 people, so still, if you figure out the millions of people who have gotten COVID this year, 1 out of 100 roughly can have a stroke. That seems to be relatively consistent. The thought is that here as well, you're getting some blood clot issue. Probably you're getting some clot that goes up to the brain, or in the brain, there's some activity there. There also seems to be the virus is all over the body, and there seem to be some of these inflammatory cells. So these are typically white blood cells, and their job generally is you get an infection, they're there to Pac-Man, chomp it up, get it out of the body, and spit it out, essentially. And that's what the vaccine is actually intended to do, is get your white blood cells primed up and say, hey, I've seen that virus. It comes in again, I'm going to go get it. So those white blood cells are there, and they're messing with the arteries, and they're causing some inflammation, and they're probably causing clotting and problems like that. I'm not sure with the vaccination. I mean, clearly there were a very few people, it wasn't a large number, with one of the agents that were getting some venous clots. I'm presuming that there are some circumstances in that case where maybe there's some association. I haven't really seen any literature suggesting that there's any significant risk of stroke associated with the vaccine. And clearly getting the disease, from my perspective, is a bigger deal, which is why I got it day 2 and would have gotten it day 1, but I was working that
day. Well, thank you. So we've obviously learned quite a bit about stroke today, and we know National Stroke Awareness. We know to act fast. We know to get to the hospital. Time is of the essence. And then live a healthy lifestyle. And as we wrap up here in our conversation about stroke, any words of wisdom or advice you want to tell our audience as we summarize?
Yeah, just in summary, listen, you can't prevent every stroke, but in general, to live a good, healthy life, you really need to be getting some exercise. And we see other things as a neurologist. That's probably the biggest factor which will help reduce your chance of getting dementia later in life. So you want to get exercise, you want to watch your blood pressure, see your doctor every now and then as they think is appropriate, and get yourself treated for that. When you have a stroke, if you notice any kind of sudden symptom, can't walk, can't talk, can't move an arm, can't see, sudden vertigo, you should call 911. Let us try to figure out, is this a stroke? And it's a challenging thing. I'm a stroke neurologist. I've been doing this for more than 2 decades, and I can't always tell initially. So I don't expect you to be doing it, especially if you're in the midst of your own symptoms. So those are the main takeaways here.
Well, great advice from Paul. Thank you again for being here with us and sharing that wisdom. And once again, from Miami Community Health, we tell you to be alert with regard to your health, live a healthy lifestyle, which is really a theme that's traversed all the topics and all the guests that I've had here. And be aware of your surroundings and those that may have a stroke. Remember, with stroke, act fast, because time is of the essence. Once again, Dr. Anthony Gonzalez, as for Dr. Paul Damski, we're signing off here from Miami Community Health.
Thank you, Tony.